What is total knee arthroplasty? It is also known as total knee replacement. It's a surgical procedure where damaged or worn out parts of the knee joint are removed and replaced with artificial components. This surgery is commonly performed to alleviate pain and improve the functionality of the knee, especially in patients suffering from conditions like osteoarthritis. The doctor will make an incision in the knee area. The doctor will remove the damaged surfaces of the knee joint and resurface the knee joint with a prosthesis. The knee prosthesis is made up of metal and plastic. The most common type of artificial knee prosthesis is a cemented prosthesis. Let us briefly review the knee anatomy. The knee is a hinge joint that is responsible for weight bearing and movement. It consists of bones, meniscus, ligaments, and tendons. The knee is designed to fulfill a number of functions. First is to support body in an upright position without the need for muscles to work. Second, it helps to lower and raise the body. Third, it provides stability. Fourth, it acts as a shock absorber. Fifth, it allows twisting of the leg. Sixth, makes walking more efficient. Seventh, it helps propel the body forward. The bones. The femur or a thigh bone, the tibia or a shin bone, and patella, a kneecap, made up the bones of the knee. The knee joints keeps these bones in place. The patella is a small triangle-shaped bone that sits at the front of the knee, within the quadriceps muscles. It is lined with the thickest layer of cartilage in the body because it endures a great deal of force. The cartilage. These are two types of cartilage in the knee. The meniscus. These are crescent-shaped discs that acts as a cushion or shock absorber so that the bone of the knee can move through the range of motion without rubbing directly against each other. The menisci also contain nerves that helps improve balance and stability and ensure the correct weight distribution between the femur and the tibia. The knee has two menisci. First is the medial. Medial is on the inner side of the knee. This is the largest of the two. Second is the lateral, on the outer side of the knee. Second is the cartilage, articular cartilage. It is found on the femur, the top of the tibia, and the back of the patella. It is a thin, shiny layer of cartilage. It acts as a shock absorber and helps bones move smoothly over one another. The ligaments. The ligaments are tough and fibrous tissue. They act like strong ropes to connect bones to other bones, preventing too much motion and promoting stability. The knee has four ligaments. The ACL, the anterior cruciate ligament, prevent the femur from sliding backward on the tibia, and the tibia from sliding forward on the femur. Second is the PCL, posterior cruciate ligament, prevents the femur from sliding forward on the tibia or the tibia from sliding backward on the femur. Third is the MCL, or medial collateral ligament. It prevents side-to-side movement of the femur. Fourth is the LCL, the lateral collateral ligaments, prevents side-to-side movement of the femur. Knee osteoarthritis. Osteoarthritis is the most common form of arthritis in the knee. It is degenerative wear and tear type of arthritis that occurs most often in people 50 years of age and older, although it may occur in younger people too. In osteoarthritis, the cartilage in the knee joint gradually wears away, and the cartilage wears away. It becomes frayed and rough, and the protective space between the bones decreases. This can result in the bone rubbing on bone and produce painful bone spurs. A knee joint affected by arthritis may be painful and inflamed. Generally, the pain develops gradually over time through sudden onset and is also passable. There are other symptoms such as the joint may become stiff and swollen, making it difficult to bend and strengthen the knee. Pain and swelling may be worse in the morning or after sitting or resting. Vigorous activity may cause pain to flare up. Loose fragments of cartilage and other tissues can interfere with the smooth motions of the joints. The knee may lock or stick during movement. It may creak, click, snap, or make a grinding noise or crepitus. Pain may cause a feeling of weakness or buckling in the knee. Many people with arthritis note increased joint pain with changes in the weather. What are the instrumentations that need to be ready and prepared when performing a total knee arthroplasty? Special specific instruments are used during the case. These includes such items. First is the major bone sets comprises bone instruments like mallets, homons, elevators, Army Navy retractors, rake retractors, and basic dissection instruments. Second are drills. That comprises drill handpiece, battery casings, reamers, and drill couplings and saw blade adapters. Third is osteotomes, or chisels, in different sizes. Fourth is total knee system sets, such as total knee arthroplasty universal miscellaneous sets, femoral component preparation instruments and trial sets, tibial preparation instruments and trial sets, different sizes of femoral and tibial insert sets, patella preparation instrumentation sets. There are additional equipments necessary for the case is prepared and inside the OR like bone cement and bone mixer like cement gun or cement bowl mixers, pulse lavage for pressure irrigations and suctions, and different sizes of knee implants such as femur, tibia, tibial articular inserts, and patella. Tourniquet application. Most surgeons prefer to carry out knee replacement surgery with the aid of a tourniquet, a tight band placed around the thigh that restricts blood flow to the knee. Potential benefits of using a tourniquet include limited blood loss during surgery and making it easier to conduct the operation. First, we have to gather different sizes of tourniquet and check for leakings before applying to the patient upper thigh. Tourniquet stockinets or soft bandage is applied before applying the tourniquet to protect the skin from pressure injury. Some surgeons may use elastic bandage to wrap around the tourniquet after application to prevent from sliding down, and some will put a silk plaster tape to secure the tourniquet in place. Connect the tubing to the tourniquet pressure port attached to the machine. Before starting the inflation, the machine setting should be done first. Pressure and time initial setting depending on the surgeon's preference are from 250 to 300 mmHg and 60 to 90 minutes, and these will be adjusted according to the surgery length. The maximum tourniquet time should be at least 2 hours or 120 minutes to avoid tissue ischemia or necrosis of the muscle or post-tourniquet syndrome. Once the surgery alarm, always update the surgeon about the current time or if additional minutes will be added. And after removing the tourniquet post-operatively, inspect the skin integrity of the thigh and report any signs of skin breaks or redness. Proper patient positioning is the most important in total knee replacement surgery. The knee replacement patients are typically placed in the supine position with arms on arm boards and the operative knee flexed. Side of the knee is supported with soft padded side support to prevent knee from falling to the side, and heel supported with soft padded heel support attached to the side of the bed to position the knee flexed and stable. Surgical techniques. A skin incision is made layer by layer. Dissection is then carried down through the deep layers to expose the knee bones. The knee joint is exposed, and osteoarthritis are seen with defects in the joint surface, shown by the blue arrows. The alignment rod is inserted in the medullary canal of the femur. Then, the distal anterior guide is placed, secured with pins. Then, distal part of the femur is then removed with an oscillating saw. A sizing guide is placed over the cut surface of the femur to determine accurate femur size of component to be implanted. The femoral finishing cutting guide is placed in the distal femur and pins are applied to hold the femoral guide securely, then use the saw to cut the four parts angle. Then the femoral trial component is placed over the femoral bone and impacted to check the good fit in all surfaces. The tibia intramedullary guide is inserted to the tibia to guide the tibial cutting block to cut the proximal tibial bone surface, and pins are inserted to hold and secure the tibial cutting block guide. Afterwards, the tibial guide is removed and the tibial surface is cut with a saw through the slot of the cutting block. Then, the bone is removed to allow the tibial trial in place. The tibial trial is placed and the hole of the tibia is drilled to accommodate the stem of the tibial component. Then the fin punch is used to create a slots for the fins of the tibial component. The tibial trial component is impacted into position, then the trial femur is reapplied. A plastic tibial insert is inserted in between the two components. The pulse lavage is connected to the irrigation, is used to remove bone fragments and to clean the bones for final components implantation. Then, the bone cement is mixed for 1 minute for implantation of each components. The femoral, tibial, and articular inserts is then implanted. Lastly, the wound is then closed and proper dressings is applied.